morning and welcome to the Michigan Peer Review Organization's Meaningful Use, PQRS, prescribing and PDSA webinar. Your host, Melissa Odinger, will now begin.
Good afternoon and thank you for joining. Today's call is going to feature information on the Plan, Do, Study, Act cycle, Meaningful Use, e-prescribing, and PQRS. There will be an opportunity to ask questions at the end of the presentation, but feel free to post in the chat section during the presentation. Our objectives for today's call is to identify the important steps in PDSA, meaningful use criteria, electronic prescribing criteria, and PQRS criteria. I'm now going to hand the call over to Sylvia, and she will go through the PDSA cycle.
Good afternoon. We just want to touch briefly on the PDSA. We won't go into a whole lot of detail, but PDSA is something that you do on a routine basis. It is based on a scientific method, and it is a four-step method used for control and continuous improvement of processes and products. So the PDSA stands for Plan, Do, Study, Act. And what you always want to do is start, obviously, with a plan. That'll always be your first step. And the other thing we want to caution right off the bat when you do PDSA is start very small. Start with one simple little step and move forward from there. So the model for improvement is a trial and learn. So what we're going to do is we're going to approach for quality improvement combining three fundamental questions. And what we want to do first is, what are you trying to accomplish? What is your goal? What is your aim that you're striving for? How are you know the change was an improvement? And that's through measure. So when you actually develop your plan, think of how you want to measure your successes and be able to determine that was actually an improvement. And number three, what changes can we make that will result in improvement? And any change can be an improvement, but to actually get an improvement, you will have to actually make a change. So the first question that we're going to look at, which is what are you trying to accomplish? What this is really doing is you want to look at what you want to actually accomplish in terms of developing a plan, developing an aim, and and the other thing I really should say is you do want to write this down so you know exactly what your goal is, how you're going to accomplish it, putting in writing also the measures and the analysis so you can review that, and so that when it comes time to actually make an adjustment, you know exactly what you have done. So what you're going to do is you're going to choose what you're going to work on. You're going to write down what you're going to do. You're going to talk and then decide how you're going to measure that, and then state the time frame that you're going to do it on. So what we have is we have an example. So this example is going to work on developing PQRS measure 22, which is the percentage of patients aged 18 and older who've been screened for tobacco use one or more times during 24 months and who received cessation counseling intervention if identified as a tobacco user. So your aim is going to be to increase the number of patients counseled for smoking cessation from 15 to 25 within 2 months. So what you're going to want to do, again, is look at small steps. You're not going to go from 15% to 100% because it really isn't going to be realistic. It might actually take several PDSA cycles to be able to get to the final percentage that you would like to have. So choose your performance measure, in this case, tobacco counseling intervention. You're going to create a baseline report, which is your initial 15%. You're going to establish goals for quality improvement, which will be your final 25%. You're going to analyze your current workflow to determine areas for improvement. Next, you're going to implement your changes, which is the plan that you actually wrote, into the workflow for improvement and apply selected CDSS strategies. Now, there isn't actually a CDSS for the most part for smoking counseling, but if you have one that actually reminds you to do the assessment, if you make them hand in hand, they will actually work well. So you're going to use your EHR to track your quality measures. You're going to measure and analyze your results, and then you're going to repeat your steps until you actually reach your goal. And don't be disappointed if your initial ones don't quite meet the measures that you want, because most people usually do set higher measures than they reasonably can achieve. But you are going to have to do this process to sustain improvement. So how are you going to know the changes in improvement? One being qualitative versus quantitative. An example of that is the percent improving would actually be your quantitative one, but the perceived quality of care may be considered to be lessened, which would be your qualitative. And that could actually just be perception. It does not really represent the fact that it might be a reality, because if your physician is focusing very much on smoking cessation and the patient isn't necessarily focused on the same goal, they may actually perceive that the quality of care is lessened, where in truth it is not. The other thing you're going to look at is monthly reports, which will clarify your aim statement and make it realistic. Integrate aim into the daily routine, and these really are changes that you'll make every single day into your workflow, and then plot your measurements monthly or even more frequently to determine that you are reaching your goals and your implementation, your plan is actually working. Number 3, what change can we make that will represent an improvement? And that can be almost anything. Change your ideas. Think outside the box. Anything goes. And borrow from other disciplines, organizations, and topics. You don't have to reinvent the wheel. If somebody else is doing it already well, talk to them and find out what they implemented to make it work for them, and follow the same process. The other proven change package, for example, is the Million Hearts campaign. Chronic care models, literature, these are all things that you can pull from for information and use. Now, the next slide really shows that change is an uphill struggle. Anytime we implement a change, it is outside usually of our comfort level, and it isn't something that is done very easily. But it is, remember, to make improvements, you are actually going to have to implement a change. Remember to start very small, follow up with your tests, and then take a look at more wide scale. So if you do your initial PDSA and it's on a very small scale and you are seeing successes, implement it across the practice, or at least on a larger scale, so that you can actually see the improvements that you're looking for. Now, PDSA is a wash, rinse, and repeat quality improvement. It really is. It's making the changes, taking a look at them. Why are they working? Why aren't they working? And then modifying it and doing it all over again. On the last slide, that's just a summary, which is, first of all, your plan, which is to state the objective of the test. And keep in mind, when you're actually doing your plan, is you are going to have to determine how you want to measure your improvement or your success. Make predictions about what will happen and why. And this is really important, because by establishing an output, the expectation, the completeness, and the accuracy of the specification is also part of the target improvement. It's information that you can look back at and actually determine how you want to move forward. And then when you're developing your plan to test change, look at who, what, where, and when. Just the 4 W's always. And again, as I had stated earlier, always start with a small scale, which is your do. So now you're actually going to test out your plan. You're going to carry out the test. You're going to implement your plan and your process changes and see how they work. Document your problems and the unexpected observances. The collection of data that you use here is going to be used for the analysis, the study, and act steps as well. So next you're going to analyze your results. You're going to study what happened, what worked, what didn't. And here is where you're going to actually figure out, all right, this is what I've got to change. So again, expect and look at your predictions, what worked, what didn't. Summarize and reflect on what you learned. Now the last one, which is your act, which is also to be considered your adjust, because this is where you're going to make your adjustments. So you're going to determine what modifications should be made, look at the deviations from the analysis of the data, and look at the root cause. Was it something you expected or didn't expect? And then prepare for the next test. So in summary, PDSA is a change. It's changes that you do every single day throughout your life. This happens to be a scientific method, but it is still just a change. Or a quote for the day is, not all changes are improvements, but all improvements are results. Avery on meaningful use. And I do want to let people know that Christy is a meaningful use expert here at MPRO, and that we have brought almost 600 providers to meaningful use through this organization. So we're going to turn it over to Christy.
Thank you, Sylvia. Good afternoon. Well, most of you have probably either already worked through your first year of Stage 1 Meaningful Use and or are in the process of working through your first year of Stage 1 Meaningful Use. In terms of looking at what you need to accomplish for 2013, if you are in the throes of this, you've got two types of measures, core objectives and menu objectives. The core objectives are mandatory. If you're participating in meaningful use, you have to do what equate at the moment to 13 core objectives, in addition to 6 to 9 clinical quality measures, which we'll talk about in a second. We also have 5 menu measures that you get to choose from out of 10. Technically, one is already chosen for you, and it's a public health measure, and we'll be speaking more about that. That involves communicating with your State Immunization Registry, or MICR, the Michigan Care Improvement Registry. So, again, you guys are working on these. A change from last year to this year involved dropping the measure that involved electronic communications. It's one advantage to working on things this year is that you do not have to send a message from one provider to another provider electronically through your electronic health record. This doesn't mean that you won't need to be doing similar things for Stage 2, but at any rate, that was the measure that was dropped. Why it went from 15 to 13. The other measure was that it was a redundancy in terms of clinical quality measures were counted as a separate measure, and while you need to do them, they took them out of the number of core measures. So at any rate, we'll talk about the 13 measures. Meanwhile, though, I want to back up for a second, and I want to ask the people that are listening if their providers are e-prescribing. So if you can take a moment to type into your, does it pop up? Type into your chat box whether, yes, your providers are e-prescribing, no, they aren't, or that you're unsure as to whether they are. Oh, wait, here we go. We've got the polling question did show up. So again, are your providers e-prescribing? A is yes, B is no, C is unsure. If you've got a second to type into that. In 2009, e-prescribing came about as an incentive program, and in 2011, CMS began reporting on their website what providers were e-prescribing as part of their quality reporting to consumers in terms of who is using technology and who is not using technology. So odds are the majority of you probably are. Let's see, it looks like we've got 50% are and we've got 50% with no answer. So at any rate, it looks like the majority of providers are e-prescribing, which is good because now it's not an incentive anymore. What it is it's mandatory, and you can avoid the penalty by e-prescribing. You don't get an extra incentive by doing e-prescribing and meaningful use. It's built into meaningful use. And the way that this is recorded with CMS is by using a G code on I shouldn't say paper claims, just from a claims basis. You use G8553 on your claim form, which indicates that something was e-prescribed. And again, this is not for refills or renewals. It's for new medications during an encounter. So faxes and phone calls do not count. It's actually sending a prescription electronically from your electronic health record to the pharmacy or to the clearinghouse. Some providers, for instance, those with NextGen, may be reporting through what's considered a registry component, where it's kind of you're sending a batch out of the registry section of your electronic health record, but the majority of people reporting e-prescribing are doing it via claims. What you want to be doing is you want to be looking at remark codes on your Medicare remittance advice to make sure that those G codes are being received, because if they're not being received, then what you're going to end up seeing are N codes, and the N code is N as in Nancy 545. If you're seeing this on your Medicare remittance advice, it means that you are already being penalized for not having e-prescribed in the previous year. If you didn't start e-prescribing in at least 2011, you ended up with a 1.5% penalty on your Medicare receivables. If you weren't doing it in 2012, you got a 2% penalty. And if you're not doing it in 2013, you're going to end up with a 2% penalty. So again, if they're counting your G codes towards your quota, you will see an N as in Nancy 365 on your Medicare remittance advice. If you are being penalized for not e-prescribing, you will see an N as in Nancy 545. If you have attested to meaningful use this year or last year or in 2011 and continue to e-prescribe and meet the threshold and you're still being penalized, contact the QualityNet help desk at 1-866-288-8912 and talk to them, because they may reverse that if you've been able to demonstrate meaningful use already. But pay attention to your remittance advice, because mistakes get made and some people are being penalized unnecessarily. So look at that. So now, in terms of core measures, so you've got your 13 measure we talked about. Your CPOE, or computerized physician order entry for medication orders, has to do with providers actually ordering medications under their login. Now, different systems are different in terms of how they allow you to set that up. Some software allows you to queue that up so that you just send it to the provider for the provider to then approve. And that counts. Some other systems, the provider actually has to enter it. You want to be familiar with what your system requires. But this is where you're going to be, from a cardiac disparity standpoint, recording, your orders for your blood pressure medications and your smoking cessation aids and those sorts of things. E-prescribing, we just talked about that. That's actually sending prescriptions electronically versus printing them out or handwriting them or faxing them. Your problem list is a big thing from a provider standpoint. It's important that providers are listing things, chronic conditions like hypertension and diabetes and chronic kidney disease, thyroid disease, sleep apnea, obesity. These are all of the hyperlipidemia. These are all things that go along with either predeterminants of potential hypertension or along with hypertension. These are the kinds of things that you want to track and pay attention to. These are all of the chronic problems, and this is generally entered by the provider, although sometimes from a data abstraction standpoint, staff will enter this initially, but the provider will maintain it. Your active medication list, one of the things that this is pretty cut and dry in terms of putting your meds down, but we want to remind you that to make sure that your medical assistants are asking patients about their over-the-counter medications. It's a common omission. Patients a lot of times don't consider things like aspirin therapy or aspirin important enough to list on their meds list, and that's kind of important. That's one of the things from a hypertension standpoint, a heart disease standpoint. You need to know who's taking aspirin. You need to know who's taking vitamin K from a clotting standpoint. All of these over-the-counter things that can affect how people respond to medications need to be recorded. So make sure that your MAs are asking who's on what over-the-counter medications. Meds allergy list, that's pretty cut and dry. Your drug interaction checks, this is obviously a safety mechanism from prescribing things to make sure that you're not prescribing something that somebody's allergic to, or that you're not prescribing something that's going to interact with another medication, which is important when you're prescribing your hypertension medications. Patient demographics, this is a big deal. Previously, ambulatory practices were not capturing race, ethnicity, and language. Hospitals were, federally qualified healthcare centers were, but general ambulatory settings were not capturing this information. Now these settings, a lot of times they're capturing it, but they're not necessarily capturing it accurately. And why is this important? Well, this program obviously talks about disparities. Disparities are when somebody doesn't get the same as everybody else. And essentially, in this case, we're talking about disparities in healthcare quality. So racial and ethnic minorities tend to receive lower quality of health care than non-minorities. This is a fact. We've already proven this across the United States. They're less likely to receive cancer screening, cardiovascular therapy, kidney dialysis, transplants, curative surgery for lung cancer, hip and knee replacements, pain meds in the ER. These are all things that we've shown. And obviously you're reporting in a program that has to do with cardiac disparities for two distinct populations, Black or African American patients and Latino or Hispanic populations. So again, this is important to collect. The big thing is understanding how to collect it and not just why you're collecting it. And if your staff doesn't understand why you're collecting it, odds are they may not be collecting it correctly. And a lot of times patients don't understand why you're collecting it, and it sometimes causes them to be defensive. And what you want to be doing is reassuring them that you're collecting this to provide better care and equitable care, not to discriminate against them and not to provide less care or lesser care. And if they can understand that being able to link race and ethnicity and language data with clinical information, it helps us make sure that there aren't any disparities. We can use quality improvement tools and techniques to address these disparities. You know, we can make sure that people have interpreters so that they have better care. So again, it's really important to, I can't stress enough, to collect this information. You can't run reports and you can't figure out who's, you know, if there are any disparities, obviously if you're not lumping people into the buckets that they need to be lumped into. And a reminder again, ethnicity is pretty easy. You've got two choices. You're either Hispanic or Latino or you're not, or you decline. So actually I guess there's three choices, so that's easier. From a race definition standpoint, a lot of patients and the general public and even staff don't understand what the race definitions are. There's American Indian or Alaskan Native. So it means that you can be an American Indian and live in South America or Central America, not just in the United States. Asian people, you're Asian if you live in the Far East or Southeast Asia or the subcontinent of India. A lot of people don't realize that if you come from India or Pakistan, you are Asian. Black or African American, that is generally pretty easy to figure out, but people don't realize that if you're living in northern Africa, it doesn't matter if your skin color is white, you are still considered in that group. And then also the reverse of that is if you live in Europe or the Middle East or North Africa, and actually I just said North Africa for black, and excuse me, it's incorrect. A person having origins in any original peoples of Europe, the Middle East, or North Africa are white. Again, it doesn't matter what color your skin color is. So again, it's important because people who belong to different groups need different medications, and we've already shown that people that belong to different groups don't always get the same care. So I'll get off my soapbox about demographics. Vital signs. Vital signs are really important when you're looking at hypertension. You've got to have your height and your weight to get your BMI. People who are obese have a tendency to head towards hypertension sooner than not. You end up needing, you know, obviously your blood pressure checked if you've got hypertension. So your four main vital signs are height, weight, BMI, and blood pressure. And smoking status is a big deal. People who smoke usually end up with hypertension and heart disease, so your smoking status and whether or not you educate people on cessation. This is where your motivational interviewing techniques come in terms of helping these people when they're ready and engaged to stop smoking. Your clinical summaries, using this as an engagement tool to get people involved in their stopping smoking or involved in taking care of their hypertension or involved in lowering their body weight and increasing their exercise and lowering salt. What kind of information can you put on your clinical summaries for them to take away to make sure that they stay engaged and participate in their own care? Your clinical decision support rule, Sylvia gave examples of smoking cessation and education is one of those. Again, a clinical decision support rule is any algorithm that's recognized across the United States that providers agree is the standard of care. An example is mammograms for women 40 years of age and older every year to 2 or 3 years, depending on insurance products. It's a lot of your preventative type services, but there are things that are providers are in agreement that in terms of how care is supposed to be provided, and then how do you follow that, and then how do you show that you're using your electronic health record to follow that. A lot of the systems have alerts that are built in that allow you, for instance, that tell you that somebody's due for hemoglobin A1C, or somebody's due for a mammogram, or somebody's due for colorectal cancer screening, or those kinds of things, or somebody with hypertension needs to have their blood pressure checked again. But it's a clinical decision support role. You're doing one of them now. For stage 2, you're going to be doing 5 of them. So this is something to think about. Privacy and security, we can't beat you over the head enough about that in terms of keeping this information safe. What are you doing with your mobile devices? If you're using any thumb drives or devices, are you making sure that stuff's encrypted? Are you how can you keep all of your information safe? Are you doing your security risk assessment annually? The Office of Civil Rights requires this whether you're a meaningful user or not. So even if you don't want to participate in meaningful use, you still better do this without having to worry about the HIPAA watchdogs breathing down your neck. Electronic copy of health information. This is if I should come into your office and say I want a copy of my records, that at least 51% of the people that ask get an electronic copy within 3 days of asking. This is something that's going to play a bigger part in stage 2 in terms of being able to push information to the portal and people having access to their information electronically instead of just on paper. So those are your core measures, not including your clinical quality measures, which we'll talk about in a second. In terms of your menu measures, we're looking at, again, you're picking 5 out of this batch, and one of them is chosen for you. You've got drug formulary checks, and this is whether or not it's turned on in your system. And if you have access to SureScripts, generally you have access to multiple formularies saying whether or not a medication is covered. And this is where you're generally trying to choose your generics and cut down on cost. Your patient reminders, are you able to send out reminders for ongoing treatment to remind your hypertensive patients to come in, or to remind those people who are borderline, or just to come in and to have their checks to make sure that you have that early detection of hypertension? Are you reminding people that they need their lab work done, or that they need visits or testing or what have you? So your patient reminders are an important component of controlling hypertension and caring for your hypertensive patients. Patient access electronically, we just talked about that a second ago in terms of being able to look at labs and certain things potentially through a patient portal, or being able to ask for medication renewals, or be able to ask for appointments. So people need to have access to you guys, not just via the telephone or the mail, but electronically. Clinical lab test results, again, are you getting this information back in a discrete format so that, for instance, your LDLs and your hemoglobin A1Cs are going into discrete boxes so that you can run reports on them. You're not just scanning these test results in because you can't track and trend data. You cannot use this information if it's just a scanned document. So your clinical lab test results, you've got to have at least 41% of that information going in discretely if you want to use this measure. Generating patient lists, are you using these lists, again, to generate who are your hypertensive patients and are they coming in? Who are your Black and Latino hypertensive patients? Are they coming in? Who's using aspirin? Who needs what kind of thing? The patient list, usually that's the cool thing about electronic health records, is that if you document stuff and check the right boxes, you can get all sorts of interesting information out of it. And being a meaningful user of this is not just stocking and storing data in this warehouse or this tool, but actually acting on the data. Generating patient lists is one way to act on this data. Medication reconciliation, for those people who are coming back to your practice after having been in the hospital or see a specialist or the emergency room or urgent care, that potentially they may have had medications changed. Are you going back through and making sure that you've got those changes recorded, and are they changes that should have transpired? Do you agree with the changes from a safety standpoint? So your transition of care patients in terms of medication reconciliation is important. You're looking at 51% of the people coming back into the office. You need to be earmarking them as what are called transition of care patients, and then looking at their meds and reconciling them and making sure you've got current meds. Patient-specific education resources. What kind of education do you have, and can you pull out of your system on hypertension or smoking cessation or obesity or low-salt diet or low-cholesterol diet, or increasing exercise that you can use and see a specialist? Are you sending somebody to the nephrologist because you can't get a handle on their hypertension? or they're heading into kidney failure? Are you sending information via your electronic health record in terms of what meds they're on and what allergies they have and where they're at in terms of lab work and so on and so forth? Generally, these systems have a canned document that pulls this information, and you send it along with a referral so these specialists know about this patient. They know what meds they're on. They're less likely to make mistakes. Or if you're going to admit somebody or you're going to send somebody to the ER, send a transition of care summary along. Immunization registry. If you practice medicine in the state of Michigan and you give immunizations, you are required to participate and send data to the immunization registry for the state of Michigan, or MPRO. The first step is creating an HL7 test message. This is a scrambled message, an encrypted message to be able to send information and show that you have the capability. The next step is after you've gotten confirmation that your test message is accurate, is letting MPRO know that you are planning on, or that you have an intent to participate in ongoing data submission, so that either when your product, your software is ready to send stuff, or you become a member of one of the HIEs, one of the sub-state health information exchanges, that you can send ongoing data. But you need to let MPRO know that once you send your message, that you're planning on continuing, and you will be expected, if you have the capability, to send this message in an ongoing manner. Syndromic surveillance, this is a newer public health measure, and the state of Michigan is ready to accept stuff now, except if your software isn't ready, it won't matter. It's going to be in a similar manner that the immunizations are sent. So this is something that you want to check with your vendor if they're ready, if you've had some kind of upgrade and you can do syndromic surveillance. Syndromic surveillance is sending symptoms to the state to go to the CDC to show whether or not we're having some sort of outbreak. It's not that you diagnose somebody yet, potentially, for instance, with influenza, but if we have a whole pocket of people who have respiratory symptoms, and is it that we have terrorism going on, or that we have some kind of outbreak, or is it that we don't have it? But it's generally before a diagnosis is figured out, but you're sending symptoms to the state to show that if we have any kind of noticeable pattern. That's what syndromic surveillance is. So lastly, clinical quality measures. I'm not going to spend a lot of time on this because we've got to talk about PQRS, and this is one of these things where you want to align everything that you're doing. Clinical quality measures are also your PQRS measures, are also some of the things that you're doing for patient-centered medical home. You've got to have 6 measures that you're working on, and you're collecting, or at least DASH is collecting information on aspirin therapy and blood pressure control and lipids management, smoking assessment and counseling, diabetes, hemoglobin A1C, pore control, BMI screening and follow-up, those kinds of things. Those all correspond or correlate to a PQRS or clinical quality measure. Something to note, though, in terms of clinical quality measures that get reported from a meaningful use standpoint, these have to be measures that your software is certified for. You've got to have 3 core measures and 3 additional measures. Should any of these measures have 0 numerators, meaning that you have, for instance, a diabetic population, but none of them have, high lipids, that you're going to end up having to pick. If you have 0s, you're going to end up needing to pick another measure. And again, if you need help, the DASH team can help you with that. But so from a clinical quality measure standpoint, again, you want to align it because you could use the same clinical quality measures for your PQRS measures. And I'm going to turn the phone over to Laura Sawyer, who is our PQRS expert. Actually, excuse me, Melissa's going to talk about audits first, and then Laura is going to talk about PQRS measures. My apologies.
Good afternoon again. Just really quick, audits for the Meaningful Use program are taking place. They are being performed by Figliozzi & Company. They were chosen by CMS to perform these audits. They are doing both pre- and post-payment audits. Practices will be notified by email or standard mail. These audits are not being performed on site. The documentation can be mailed or uploaded to an electronic portal, and the instructions for that are included in the notification. You will have 2 weeks to submit any requested documentation, so we're recommending that you retain all your documentation you used for your meaningful use attestation for 6 years. Some things that you might want to hold on to would include the meaningful use report that you use to attest, any screenshots of your yes-no attestations, including the drug-to-drug, drug allergy interaction, the CDS alerts, the key clinical exchange, which, as Christy mentioned, is no longer a measure for 2013, but if you attested in 2011 or 2012, this was part of your attestation. If you use the menu measure of a patient list or drug formulary, you should have screenshots of those. Also, a copy of your contract from your vendor, a copy of the letter you received from MPRO saying that your submission was successful, and also the certified EHR number from the Chapel website that you used when you attested. Now we'll have another polling question, and then we'll get into PQRS.
Thank you, Melissa. Our polling question today is, are your providers currently participating in the Physician Quality Reporting System known as PQRS? And you can answer yes, no, or unsure. And if you are participating in PQRS, how is your data being submitted? And our choices here are claims, EHR, registry, other, or unsure. Let's get into some PQRS. PQRS, also known as Physician Quality Reporting System, is a voluntary reporting program established by CMS in 2007. In the program, professionals can report information to Medicare about the quality of care they provide Medicare Part B patients with certain medical conditions. PQRS is part of a broader CMS initiative aimed at advancing quality and efficiency in healthcare and moving toward a system in which CMS purchases services based on value rather than volume. And it looks like we have our poll results in, and we have about 33% that are participating, 17% is unsure, and 50% did not answer. And of those participating, it looks like it's divided up between claims, registry, and then also unsure. Okay, moving on. The PQRS program uses both incentive payments and then also payment adjustments to promote participation. This year in 2013, if you do participate in PQRS, you are eligible for 0.5% of your Medicare charges if you successfully report. Then you will receive a 1.5% payment adjustment on your Medicare receivables in 2015. This 1.5% goes up to 2% in 2016 if you do not participate in PQRS in 2014. Now we'll go into criteria of how to successfully report PQRS data. One of the methods is through your claims. To report through claims, you'll want to choose 3 PQRS measures, and you'll want to report on 50% or more of your applicable Medicare Part B patients. You'll report this data for 12 months starting January 1st, ending December 31st. You can also report a measure group through claims, and you'll report the measure group for 20 Medicare Part B patients, and you'll report this data for 12 months. Another way to report your PQRS data is through a registry. For the registry, again, you'll choose 3 individual PQRS measures. You'll want to report on 80% of your Medicare Part B patients, and you'll report this data for 12 months. You may also choose to report on 1 measure group for 20 patients, and in this option, you can choose to report for 12 months starting January 1st to December 31st, or you can choose to report for 6 months from July 1st to December 31st. The 6-month reporting option is only available if reporting through the registry. Finally, you can also choose to report through your qualified EHR system. And for this option, you would choose 3 individual PQRS measures. You would report on 80% or more of your Medicare Part B patients, and you would report on data for 12 months. Finally, we'll go into avoiding the 2015 PQRS penalty. There's 3 different ways to avoid this penalty, and the first would be to satisfactorily report PQRS data to earn the PQRS incentive. That's what we just discussed about reporting through claims, registry, or EHR. If you choose not to earn the incentive but simply avoid the penalty, you may report one measure or measure group using either claims, registry, or an EHR system. And lastly, you can elect to be analyzed under the administrative claims-based reporting mechanism, and you would choose or elect that by October 15, 2013. Under this option, CMS would calculate your quality performance based on administrative claims on a set of 17 measures. If you choose this option, then you would want to use your IX account to elect the administrative claims. Okay, I'm going to hand it over to Melissa for some announcements.
I wanted to thank everyone again for joining the call. Just some quick announcements before we finish up or get to questions. First, the Disparities in Cardiac Health program now has a listserv. We will be sending out emails with login instructions. Once you get those, please log in and take a look. Offer new topics for suggestions and share best practices with your colleagues. The change packages regarding hypertension and disparities are being distributed. If you require more copies or would like to receive an electronic version, please email your request to the DASH team at dash@mpro.org. And if you haven't pledged to live a healthier life by knowing the risk factors associated with high blood pressure, please visit the Million Hearts Initiative website and take the pledge. This will now be able to open the lines for questioning. Operator, if you could please give instructions.
Ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Again, if there are any questions or comments at this time, please press the number 1 key. All right, there are no questions in queue.
We did receive one question in the chat regarding if we have anything that we can send that would indicate definitions of the race. And the answer to that is yes. If you send your email address to the dash@mpro.org website, we'll be able to send you a document back that you can share with your staff. This PowerPoint presentation and audio will be posted on the MPRO website. And a couple other announcements. Our next webinar will be September 19th, and in that webinar we'll be discussing data that we've collected so far in both the Disparities in Cardiac Health program and also our Cardiac Learning and Action Network. Another save the date is for October 18th. The Disparities in Cardiac Health and Cardiac Learning and Action Network are having a collaborative conference in East Lansing. All providers will be receiving a save the date postcard. Registration is now available on the mpro.org website. As always, if you have any questions about anything that was on the presentation, please email the DASH team at dash@mpro.org. And I wanted to just have everybody, if you could please fill out the survey before you disconnect. And thank you for joining.